Good day, everyone. This is Group 6A, and we're going to talk about our case report, focusing on spondylodiscitis caused by Enterobacter agglomerans. This topic will be divided into three parts: the introduction, the case presentation, also the discussion. For the introduction,
Spondylitis caused by Enterobacter agglomerans. What is spondylodiscitis? Spondylodiscitis can be defined as a primary infection accompanied by destruction of the intervertebral disc, with secondary infections of the vertebrae. In almost 50% of cases of spondylodiscitis, a distal focus of infection has been identified. In genitourinary tract, 17%, skin and soft tissue, 11%, intravascular devices, 5%, gastrointestinal tract, 5%, respiratory tract 2%, and oral cavity 2%. In blood culture, is a simple method for identifying bacterial agents of spondylodiscitis as the infection is mostly monomicrobial. Spondylodiscitis following Enterobacter agglomerans species is unusual around the globe. Only 31 suspected cases have been previously reported. However, organism was not isolated in all cases. Enterobacter agglomerans causes bacteremia, lower respiratory tract infections, skin and soft tissues infections, urinary tract infections, endocarditis, intra-abdominal infections, septic arthritis, osteomyelitis, CNS infections, and ophthalmic infections in immunocompromised individuals and associated with intravenous lines.
now we will proceed with the case representation. This is our case. A 65-year-old farming lady admitted to the hospital having 3-month history of on and off dysuria and renal colic. She was continuously febrile. While being in hospital, she has developed sudden onset bilateral lower limb weakness and severe backache. There was no history of trauma and fall and no recent weight loss. Her appetite was good. There was no past or contact history of tuberculosis. Physical examination revealed tenderness to palpitation over the 10th and 11th thoracic vertebrae. The neurologic examination reveals spastic paraparesis with hyperreflexia. Her cranial neuron examination was normal and she is well oriented. Her total white cell count was 16,900 cubic millimeter and with 90.45% of granulocytes, 5.6 lymphocytes, and 1.0 monocytes. Erythrocyte sedimentation rate was 120 millimeter per hour, and CRP was 42 milligram per DL. Her magnetic resonance imaging and CT scan of the thoracic spine revealed severe thoracic T10 and T11 discitis with minimal soft tissues component and vertebral body destruction. Features are suggestive of Asian variety of tuberculosis spondylodiscitis rather than pyogenic spondylodiscitis. There were no contagious spread and no epidural and psoas muscle abscess were found. So we're in doubt to use the trial of anti-tuberculosis anti-therapy or an empiric antibiotic to cover common microbes causing pyogenic spondylodiscitis. Blood culture revealed Enterobacter agglomerans within 41 hours of incubation in 99.9 probability from Rammel identification system. Isolate was susceptible to ciprofloxacin, carbapenems, and aminoglycosides, and resistant to ceftazidime and aztreozam. We have started intravenous ciprofloxacin 400 milligrams 12 hours with weak monitoring of the S. So for a more condensed report, it will be given by Mrs. Carr. And then her CT scan or guided biopsy culture was negative for bacteria, fungi, and tuberculosis. Histology shows possible bacterial infection. Chest X-ray radiography is normal and Mantox test was negative. Imaging study of genitourinary system shows calculus over renal pelvis. Urine culture was also negative for bacteria. A patient was successfully treated with intravenous ciprofloxacin of 400 milligrams 12 hours for 3 weeks, followed with 3 weeks of oral ciprofloxacin. There were a follow-up examination on the 6-week on completion of treatment showed mild residual bilateral lower limb weakness and ability to walk with aid. Follow-up by CT scan in 6 weeks shows T10 and T11 vertebral body and disc regeneration.
Okay, so for the summary of the presented case, the patient's symptoms upon admissions were 3-month history of on and off dysuria. Dysuria, guys, is yung pain or discomfort when urinating. And then renal colic naman is abdominal pain commonly caused by obstruction of ureter from dislodged kidney stones. And the patient was also continuously afebrile, meaning ng afebrile is not feverish. So while the patient was admitted, she developed sudden onset bilateral lower limb weakness and severe backache. For the results of the physical exam, there was tenderness to palpation over the 10th and 11th thoracic vertebrae. For the neurologic exam, it reveals spastic paraparesis with hyperreflexia. Spastic paraparesis it causes gradual weakness with muscle spasms. And then for the cranial neuron exam, it was normal and the patient was well oriented. So for the results, the total white cell count is 16,900 cubic millimeters. The normal count is only 4,400 to 11,300. And there were 90.45% granulocytes, 5.6% lymphocytes, and 1% monocytes. For the ESR, 120 millimeters per hour, the normal range is 0 to 10. And for the CRP is 42 mg per dl. The normal rate is less than 0.6 mg per dl. For the MRI and CT of the thoracic spine, it revealed severe thoracic discitis with minimal soft tissue component and vertebral body destruction. It is suggestive of Asian variety of tuberculosis spondylodiscitis rather than pyogenic spondylodiscitis. So tubercular spondylodiscitis usually occurs in the thoracic spine, while itong pyogenic spondylodiscitis occurs in the lumbar spine. So there is no contiguous spread and no epidural and psoas muscles abscesses were found. For the blood culture, revealed Enterobacter agglomerans with 41-hour incubation in 99.9% probability from Ramal identification system. So the isolate was susceptible to ciprofloxacin, carbapenems, and aminoglycosides. And the isolate was resistant to ceftazidime and aztreonam. For the treatment, intravenous ciprofloxacin, 400 milligrams 12 hourly with weekly monitoring of ESR.
Now let's move to the case discussion, which will be given by Ms. Lariba.
So for the
As you
case
can see here,
discussion, introduction of discussion spondylodiscitis caused by Enterobacter agglomerans. So in Table 1, clinical response and change of ESR with time following parenteral and oral ciprofloxacin in treatment. In ESR, week 0, 120, week 1, 100, week 2, 80, week 3, 70, week 4, 26, week 5, 12, and week 6, 13. In the lower limb power, in week 0, 0 to 5, week 1, 0 to 5, week 2 to week 3, 1 to 5, week 4, 3 to 5, week 5, 4 to 5, and week 6 is 5 to 5.
so basically table 1 shows the response of the patient with the oral treatment. So as you can see in the ESR, it is slowly degrading as the weeks pass by with the ongoing treatment of ciprofloxacin. So the lower limb power from week 0 to 1 was 0 over 5. Week 2 and 3 was 1 over 5. And week 4 was 3 over 5. And week 5 was 4 over 5, and so on and so forth.
In clinical grounds, differentiation of pyogenic and tuberculous spondylodiscitis is well defined. Tuberculous spondylodiscitis requires minimal of 1 year anti-tuberculous treatment. Pyogenic spondylodiscitis, it requires a minimum of 6 weeks of targeted antimicrobial therapy. In both instances with targeted therapy in such time period, neurological sequela is reversible. Often the diagnosis of spondylodiscitis is delayed and leads to poorer prognosis. Enterobacter agglomerans is in family Enterobacteriaceae. It causes opportunistic human infections, mostly as wound infection following contamination of plant material and as hospital-acquired infections. So Enterobacter agglomerans is the new name of Enterobacter agglomerans is Pantoia agglomerans. So Enterobacter agglomerans is formerly known as Pantoia agglomerans. So the case of the lady. The lady presented sudden onset paraparesis, which means it's leaning towards being pyogenic in origin. So paraparesis is the lower limbs is the paralysis was not continuous or it is partial. Throughout this period, this lady was afebrile. Computed topography and magnetic resonance imaging studies show thoracic vertebral involvement with extensive destruction of T10 and T11 vertebral bodies and T10, T11 disc destruction.
So as you can see in the top right picture, that you can see the T11 and the T10 vertebral bodies disc destruction.
Tuberculous spondylodiscitis mainly affects thoracic and lumbar vertebral columns and leads to extensive destruction of vertebral bodies, while pyogenic spondylodiscitis involves lumbar vertebra and disinvolvement with minimal vertebral body destruction seen. T10 and T11 vertebrae have extensive destruction that favors tuberculous spondylodiscitis. So as you can see, the T10 and T11 vertebrae in the image has extensive destruction. ESR value of 120 mm in the first hour favors tuberculosis in origin. Spondylodiscitis following gram-negative bacteria and Mycobacterium tuberculosis have some overlapping features. Gram-negative bacterial spondylodiscitis is more likely to be lower levels of inflammatory markers and less abscess formation. Destruction of this is common. In this case, CT-guided biopsy for bacterial culture was negative, but histology favors bacterial infection. Enterobacter agglomerans histological features are suggestive of granulomatous inflammation. So granulomatous inflammation is a distinctive pattern of chronic inflammatory reaction characterized by focal accumulation of activated macrophages. So rather than bacterial variety. That is why it's more leaning towards tuberculous spondylodiscitis. Later on, teeth tuberculous culture was found to be negative on follow-up. Enterobacter agglomerans was detected in blood culture. The diagnosis shifted towards pyogenic spondylodiscitis. Blood culture became positive 41 hours following incubation, which makes it hard to declare it as the potent etiologic agent for pyogenic spondylodiscitis. This lady had 3-month history of on and off dysuria associated with renal calculus. Enterobacter agglomerans, pyelonephritis, and urinary tract infections have been described, but association with renal calculus is been not described. This lady did not have clinical features of pyelonephritis, but urine full reports show 100 to 100 pus cells in high power field. So, and urine culture having no growth. Still, the association of renal calculi with Enterobacter agglomerans could not be excluded. So, for the treatment and recovery, Since initial diagnosis as pyogenic spondylodiscitis was doubtful, following with blood culture positivity of Enterobacter agglomerans, they have started trial of antimicrobials rather than antituberculosis treatment. They have used ESR as prognostic marker of spondylodiscitis. So ESR is a test where you put your blood into the test tube and the red blood cell will show if your blood is normal or not, or the red blood cells will fall. So that's what you call ESR. With the continuation of ciprofloxacin, ESR dramatically responded. Simultaneously, clinical response was seen as her paraparesis, showing gradual improvement where lower limbs tend to move, and with the completion of 6 weeks of treatment power, it became 5/5 as she was capable of walking with aid. Subsequently, she became totally independent and returned to her day-to-day activities in total of 2 months. Throughout this period, she was on physiotherapy. Blood culture has a role in the diagnosis of spondylodiscitis. Further, ESR can be used as an important inflammatory marker in monitoring the response to treatment. Retrospectively, ESR would aid in reaching a definitive diagnosis. So, as you can see, the lady was having a clinical response. She shows gradual improvement in paraparesis, and she goes back to normal after 6 weeks of treatment.
Yes. So basically, it was hard for the physicians to conclude if it was tuberculosis spondylodiscitis simply because the culture of the tuberculosis was negative. And with the ESR as the prognostic marker of spondylodiscitis, they were able to uh, conclude that it was Enterobacter agglomerans, the cause of the spondylodiscitis of the lady. And with the treatment, as you saw from the table on how her ESR dropped slowly as week passed by, it was the diagnosis and also the treatment was also successful. So thank you so much for listening. That would be all. Thank you.